There are many drugs employed in the production of general anesthesia and intravenous conscious sedation techniques that have a marked effect on the patient's respiration. Basically, there are two sites of action for this effect. Marked depression of the so-called respiratory center in the area of the medulla and pons from drugs represents one side of action. The depression of the respiratory center can be of many degrees and may therefore produce varying degrees of hypoventilation to apnea. The second side of action for drugs that affect respiration is the myoneural junction on skeletal muscle fibers used in the production of respiratory movements. There are two groups of drugs, the depolarizing muscle relaxants and the non-depolarizing muscle relaxants, which have the ability to block acetylcholine from reaching the skeletal muscle fiber receptor site, and in this manner produce varying degrees of paralysis of the muscles of respiration. For the clinical practice of dentistry, it is important to understand the effect that various drugs have upon respiration. The utilization of barbiturates and narcotic analgesics by either oral, intramuscular, or intravenous administration can lead to undesirable effects on the respiratory system and place the patient in a compromised physiologic state. The occurrence of grand mal seizures and its effect on respiration in the dental office is of such incidence that possible treatment of such an event at some time during your dental career is a distinct possibility. Also, the ability to recognize and treat important dearrangements of respiration represents an important facet of cardiopulmonary resuscitation. To demonstrate the respiratory effect of drugs commonly employed in the anesthetic management of patients, a dog has been intubated to control his airway. An intravenous line has been placed to maintain hydration and serve as an avenue for administering intravenous drugs. Transducers have been placed on each side of the chest wall to record excursions of the thoracic cage. Normal patterns of chest movement have been recorded and utilized as a baseline. An anesthetic machine using 2 liters per minute of oxygen flow has been connected to the endotracheal tube and will be used to control ventilation during periods of respiratory arrest. A normal pattern of respiratory activity is seen in the animal initially. Thiopentyl sodium is injected intravenously at this point with rapid development of the apneic state. Respiration is assisted manually through this period. Persistence of apnea is shown here with manually assisted respirations. A longer period of apnea is shown with the first spontaneous breathing effort occurring at this point. The The respiratory pattern is now approaching normal. Important clinical points. 1. Thiopentyl sodium is an ultra-short-acting barbiturate. 2. Primarily used for induction of general anesthesia, can be used in intravenous conscious sedation techniques. 3. Effect is dose-related, can produce sedation, hypnosis, coma, death. 4. Primary site of action is the reticular formation. 5. Effect on respiration is by depression of central respiratory center. 6. Apneic states produced by ultra-short-acting barbiturates will require assisted or controlled breathing for the patient. 7. Respiratory depression by barbiturates can be antagonized. Animal has received a sufficient intravenous dose of thiopentyl sodium to produce an apneic state, as shown here, together with controlled respiration. An intravenous dose of dopram has now been administered, producing within a few minutes' time an augmented pattern of respiratory activity, as demonstrated here. And here. Important clinical points. 1. Dopram is intended for use in barbiturate depression, not narcotic depression. 2. Patients who have received stimulant drugs to antagonize depressant drugs should be followed closely postoperatively. 3. Effect on respiration is by stimulation of the central respiratory center. This tracing strip shows the transition from normal respiratory pattern here to a depressed rate and tidal volume here. This respiratory depressant effect was produced by the intravenous administration of fentanyl. Important clinical points. 1. Commonly employed narcotic analgesics used in dentistry can produce respiratory depression. 2. Respiratory and analgesic effects of fentanyl are rapid in onset and have a short duration of effect, in contrast to agents such as morphine, which has a slow onset with a long duration of effect. 3. Primary site of action of narcotic analgesics is the thalamus. 4. The respiratory depressant action of narcotic analgesics is due to elevation of the threshold of cells in the respiratory center to carbon dioxide stimulation. 5. Narcotic respiratory depression can lead to hypoventilation, resulting in hypercarbia and hypoxemia. 6. Commonly employed in dentistry for pain control and is part of intravenous conscious sedation techniques. 7. Respiratory depression by narcotics can be antagonized. Following the narcotic-induced respiratory depression tracing strip, the persistence of respiratory depression is exhibited here at the point of intravenous administration of Narcan. The reversal of respiratory depression is shown at this point. Important clinical points. 1. Narcan is intended for use in narcotic depression, not barbiturate depression. 2. Patients who have received stimulant drugs to antagonize depressant drugs should be followed closely postoperatively. 3. Effect on respiration is by reducing threshold elevating effect to carbon dioxide produced by narcotic analgesics. 4. Some narcotic antagonists can produce further respiratory depression if given in excessive dosage. This tracing strip shows a normal respiratory pattern in the test animal at this point. Manually controlled hyperventilation of the animal started here and continued to this point. With cessation of the hyperventilation, a state of apnea is produced for this time interval, showing at this point the first spontaneous breathing effort. Normal respiration has been restored at this point. Important clinical points. 1. Hyperventilation is commonly seen in the fearful, apprehensive dental patient. 2. Hyperventilation lowers the alveolar partial pressure of carbon dioxide. 3. Hyperventilation produces respiratory alkalosis with clinical symptoms of paresthesia and syncope. 4. Correction of hyperventilation is by rebreathing of respired gases to increase the partial pressure of carbon dioxide. 5. Site of action of respiratory effects of carbon dioxide is at the cellular level of the respiratory center. This tracing shows the transition of a normal pattern of respiration, as shown in this segment, to one of mild hyperventilation in this segment. This effect was produced by the addition of small amounts of carbon dioxide to the breathing circuit of a spontaneously breathing animal. The carbon dioxide addition was of short duration, and slow return to normal respiration is seen through this segment. Important clinical points. 1. Hyperventilation will result in the normal individual if the alveolar partial pressure of carbon dioxide is increased. 2. Hyperventilation will not result in the individual with narcotic-induced respiratory depression. 3. Narcotic-induced respiratory depression will give rise to hypoventilation even though there is an increased alveolar partial pressure of carbon dioxide. Hypoventilation will produce respiratory acidosis, hypercarbia, and hypoxia. A normal respiratory pattern is seen in the test animal at this point. Succinylcholine is administered here, with fasciculations occurring in the animal in this segment, and apnea produced at this point. Assisted respiration is maintained during the period of apnea. Assisted respirations are continued at this point, with beginning spontaneous respirations occurring at this point and through this segment. Important clinical points. 1. Succinylcholine is a depolarizing muscle relaxant. 2. There is a short duration of drug action. 3. Can be used to terminate persistent grand mal seizures. 4. The use of this drug will require the ability to maintain an open airway and ventilate your patient until return of spontaneous breathing. 5. Used most frequently in general anesthesia to aid in the intubation of the trachea, producing paralysis of the vocal cords. 6. Fasciculations of skeletal muscle is characteristic in the use of this drug. The transition from normal respiration to respiratory paralysis following the intravenous administration of tubocurarine is seen in this segment. Assisted respiration is started at this point. Assisted respirations are continued through this segment. Persistent apnea is demonstrated in this segment when assisted respiration is stopped. To the beginning of assisted respirations again. Important clinical points. 1. Tubocurarine is a non-depolarizing muscle relaxant. 2. There is a long duration of drug action. 3. Has no clinical application in the dental office. 4. Used in general anesthesia for the production of long-term skeletal muscle paralysis. 5. Skeletal muscle fasciculation is not characteristic in the use of this drug. The continuing persistent apnea is demonstrated again in this segment in the animal paralyzed with tubocurarine. Reversal of skeletal muscle paralysis is accomplished by the intravenous administration of atropine and prostigmine at this point. Assisted respiration is maintained for a short time, and beginning spontaneous breathing activity starts at this point, progressing to a normal respiratory pattern. Important clinical points. 1. Prostigmine is an acetylcholine esterase inhibitor which allows choline to increase its concentration at the myoneural junction. 2. Prostigmine also produces a vagal effect on the heart. 3. Atropine, the muscarinic action of acetylcholine, has no effect on the nicotine action of acetylcholine. 4. Atropine, therefore, prevents the production of a bradycardia during the reversal of tubocurarine paralysis. The aforementioned drugs represent but a few of the many drugs that may affect respiratory activity. In particular reference to the clinical use of intravenous conscious sedation techniques where potent narcotic analgesics are to be employed, it is imperative that states of respiratory depression be recognized and corrected. Know the potential effects on respiratory activity of drugs you administer to your patient. is an ultra-short-acting barbiturate. 2, primarily used for induction of general anesthesia, can be used in intravenous conscious sedation techniques. 3, effect is dose-related, can produce sedation, hypnosis, coma, death. 4, primary site of action is the reticular formation. 5, effect on respiration is by depression of central respiratory center. 6, apneic states produced by ultra-short-acting barbiturates